Good afternoon and welcome to this webinar on the engineering response to COVID-19, brought to you by the Institution of Mechanical Engineers. My name is Dr. Jen Baxter and I'm the Chief Engineer here at the institution. Today we are very fortunate to have a number of speakers who will be explaining the challenges that engineers have responded to over the past weeks and some of the solutions that have emerged from that process. The agenda we have for this webinar is that we will have 2 short talks followed by a panel session where questions can be asked. Please feel free to submit questions throughout the talks as it will actually help me to organise these for the panel session. And if possible, could you please state who the question is for? So to begin with, we will have a talk from Dr. Helen Meese, who is the CEO and founder of the Care Machine and also a trustee of IMechE, along with Bassett Abdul, who is a healthcare science fellow with the NHS. This will then be followed by a talk from Alex Dickinson, Associate Professor in Engineering and Physical Sciences at the University of Southampton. So with that, let's go over to Helen and Bassett and hear their talk.
Thanks very much, Jen. Good morning, everyone. Bassett and I are going to take 10 minutes or so to talk to you about the vital role of engineering at the Nightingale Hospital in London in a clinical context, that being the use and management of technology at the patient bedside. But before that, for those of you who are not familiar with engineering in the clinical setting, Bassett is going to give you an overview of healthcare science and where clinical engineering sits within that community. And he's also going to share with you how those engineers work within that community. And he's going to talk a little bit about how the engineers are deployed at Nightingale and how they've been upskilled over the last few weeks. And finally, I'm going to talk a little bit about how we've engaged with the wider engineering community to help support the clinical engineers at Nightingale. So over to you, Bassett, to give the overview.
Thanks, Helen. Let's start with what is healthcare science. It is a professional identity in the UK, just like other healthcare professions, including doctors and nurses and allied health professions, or AHPs. There are more than 50 healthcare-related scientific, engineering, and technical specialist divisions within healthcare science, which are divided into 4 themes. As the audience is predominantly engineers, let's talk about numbers. So there are around 55,000 healthcare scientists in the UK, which is around 5% of the NHS workforce. However, this 5% workforce makes an impact on 85% of diagnosis. So a very important job role of a niche workforce. Among the 4 themes I just mentioned include, first one will be life sciences. That covers all lab-based roles like pathology, biochemistry, virology, and many more. The next one is physiological sciences, and this includes audiology, cardiac physiology, critical care science specialisms. The third theme is physical sciences. That covers nuclear medicine, radiotherapy physics, and my very own clinical engineering specialism. And the final fourth theme is bioinformatics, that covers specialisms like genomics and health informatics. Every healthcare science specialism has a unique, role, a very important role in COVID environment and in general as well. Sorry, my slides missed a little bit. I need to reach there. Apologies. So in the current COVID environment, life sciences, for example, the colleagues in life sciences are doing all the COVID testing. In terms of engineering and equipment-focused environments like ITU, the critical care science and clinical engineers are at the forefront. The critical care scientists or healthcare scientists in critical care domain support equipment setup by the bedside. They perform routine functional tests, they deliver user training, carry out troubleshooting, and assist in clinical teams in specific medical procedures, whereas clinical engineers perform commissioning, acceptance testing, repairs, and maintenance of medical devices like ventilators, dialysis machines, and all the other equipment, including patient monitors, infusion devices, etc. Clinical engineers also perform governance, quality assurance, external maintenance, contract management, and train clinical colleagues, including doctors and nurses, on use of medical devices. In response to COVID, as we know, every hospital increased their ITU capacity. Plus, we got London Nightingale Hospital, which I believe is a blessing. So we, healthcare scientists, had to urgently fill the workforce gaps in these two professions I mentioned. As a result, a call was made to healthcare science community to voluntary redeployment, and we identified 60 healthcare scientists from various specialisms, as mentioned here, and we upskilled them through a rapid training program to work as clinical engineers and critical care healthcare scientists. In the rapid training program, there is a 1-day clinical ventilation course, a 2-day face-to-face plus 12-hour online technical course, and then comes equipment manufacturer training, and finally, hospital induction. I'm glad to share that we developed and organized this training within 5 days and delivered in 6 days. So we upskilled 60 healthcare scientists in 6 days, and this all is down to an amazing healthcare science team effort. When I asked the trainees why they volunteered for the Nightingale Hospital, the responses have single theme, I would say, and that is to use their skills in most needy settings. I think it is very moving. I love my healthcare science colleagues. They are indeed amazing. When I asked them what transferable skills they found useful to be trained for a new environment, I just picked a couple of responses here. And that represents the main theme that their clinical decision-making skills, their long NHS career as scientists, and understanding of medical equipment helps them fast-track redeployment. And finally, the course was very well received, and we are working on next cohorts. The story doesn't finish here. Just like at Nightingale Hospital, healthcare scientists are redeployed within their employing NHS trust on similar very critical roles. So we have only a finite quantity of these amazing workforce. Therefore, external support is required to provide a sustained engineering and technical workforce at Nightingale Hospital. Here comes the part of the puzzle amazingly played by Helen, and I pass on to her to share that. Thanks.
Jump on. Thank you, Bassett. So as you've heard, Bassett has outlined the delivery of the technical services within the hospital, and it was required at a size and speed that had really never been undertaken before. And this was something that the healthcare science team recognised very early on in the process, well before the hospital began to take shape. Now, for those of you listening today, we're mostly engineers, and I'm guessing that most of you will be familiar with the processes of risk analysis and mitigation, and ensuring that was that there was a big enough cohort of engineers to manage the equipment for potentially what had been outlined as 4,000 beds was going to be a major task that needed to be understood and addressed. With this in mind, the HCS team reached out to me with this very question. Now, I can tell you, I've been handed some critical requirements before, but this was possibly the biggest one I've ever faced. But whether you're building a skyscraper, whether you're working on aircraft, or whether you're putting together a professional engineering team, the processes are fundamentally the same. And as engineers, that's what we're trained to do. Working with the team, we began to define the requirements of what this engineer would look like, what sort of skills they would need, and what tasks they were going to undertake. We evaluated the existing job descriptions of a range of clinical engineering roles and drew on those to create the requirements from that, recognising, of course, that they were going to need additional training and supervision throughout the process. From this, we created a criteria of essential needs and desirable qualities, which came to define our newly named auxiliary engineering support role. As clinical engineers are expected to work towards chartership during their career and are often members of IPEM, one of our sister institutions, the Institution of Physics and Engineering and Medicine, to ensure the highest levels of professionalism and training, we recognised that we were going to need to call on all 38 professional engineering institutions, and that was going to be fundamental in ensuring that the auxiliary engineers met the same sorts of standards as the clinical engineers. But to do that was going to be quite a task. Now, fortunately, we were able to reach out to the Royal Academy of Engineering and ask them for help in achieving this quite considerable goal, and they very kindly said yes. I worked with their policy team to put together a database as well as supporting statements and information for the PEIs so that they could clearly understand the requirements. As I said at the start, it's important to ensure a quality process at all stages of this call, and good communication played a key role in ensuring that that happened. With the database set up and the PEIs informed, I have to say I was holding my breath to see if anybody actually signed up. I didn't really have to wait that long. We had 600 volunteers within the first 24 hours, and subsequently we have now reached over 1,000 volunteers, and that's happened this week on a wider call across the UK to support the other Nightingale hospitals. We've now selected the first group of auxiliary engineers to take up posts at the London site, and they will be starting their training in the coming weeks, which will involve, as Bassett has already pointed out, a one-day online course followed by several days of on-site training with some very intensive training, all supervised by the clinical engineers themselves. I think the key thing for me throughout this has been the word flexibility. Engineers have an innate ability to form themselves around a situation and to deal with complex requirements and problems, but in completely uncharted waters such as this pandemic, it is often much harder to see not just the problem but also the solutions to address it. What has come to the fore in this particular case is that the engineering community as a whole has been flexible enough to take on new roles and responsibilities to enable others to achieve their goals. And that for me has been a wonderful thing to be part of. Now, I'm sure you will have quite a lot of questions for both myself and Bassett, but we'll get to those later on. So for now, thank you very much. And I'll pass on now to Alex and his presentation.
Thanks, Helen Bassett. That's a really informative talk and quite an incredible response from engineers. And as Helen mentioned, we will now hear from Alex Dickinson.
Hello, thank you very much for the kind invitation to present a case study of an engineering development which we've undertaken in this same remit. In this case, the Perso prototype respirator for healthcare workers. I'm going to cover an intensive development activity, much like the first design assignment that we give our first year mechanical engineering students at the University of Southampton, and actually using the same materials and facilities that we give them. I'll also cover some issues which others working on similar projects might like to consider. In early March, a Lancet editorial stated very simply that our healthcare workers are every country's most valuable resource, and I think this is now clear to all of us. We've seen reports that 1 in 5 healthcare workers treating COVID-19 cases in Italy have become infected, making up nearly 1 in 10 of the country's cases. This situation leads to significant staff absence and, unfortunately, in some cases, mortality at a critical point during the pandemic. Personal protective equipment plays a crucial role in control programs where vaccination isn't available. And there's some international evidence that many healthcare workers receive limited PPE provision and training prior to a pandemic, certainly relating to PPE which doesn't relate to their day-to-day job. During the current pandemic, global stock of PPE is low, and in some places experiencing high infection incidents, supplies of PPE run out. Now, mask-type respirators can be uncomfortable, pressing on the bridge of the nose and cheeks for warm for 8 or 9 hours, as shown in this photo from Dr. Natalie Sylvia, a key Twitter influencer, and I believe registrar and anaesthetist. Furthermore, these respirators don't fit all face shapes, and they don't protect against everything. For example, the N95 or FFP3 masks, which you may have read about, those standards permit up to 5% inward air leakage. Finally, where patient testing is limited, or in individuals where a viral load is below the limit of detection because they may have recently been exposed, false negative test results might lead to infectious patients receiving care on wards where no PPE is worn. So we set out to tackle this challenge, responding to a call from our clinical lead late on Monday, 16th of March, and we received this sketch. He proposed a concept building upon the principle of a powered air purifying respirator, or PAPR. This would have the potential advantages over mask-type respirators of lower inward air leakage, higher efficiency of air filtration, protection from splashes, and would also prevent the user from touching their own face inadvertently. Also, the user would not need to spend lots of time changing their masks and PPE between seeing patients, which could considerably improve each clinician's efficiency. Now, the concept of PAPR, or this kind of respirator, is not at all new, and I don't want to pretend that we invented it. However, commercially available devices are quite expensive and had very low availability even when we took up this project. Therefore, we aim to build something using off-the-shelf parts where possible and create our own universal connectors and use the fewest, simplest manufacturing steps possible where we had to produce our own components. For people developing PAPRs, we have a standard, a British and European standard, which specifies the general performance, but there are also some very specific requirements for a PAPR for this particular use case. A group of informed potential users gave us these additional requirements based around safety and comfort, communication, visibility of the healthcarer's face to their patients, and adjustability to fit users of different heights and head sizes. The device would need to be stable during movement around the hospital, for example, bending over, and especially activities like performing CPR, which most other powered air purifying respirators aren't always designed for. The clinician suggested that the device would ideally have a lifespan over the duration of the pandemic, so it would be a multiple use but single user device. Now, all of these requirements put specific restrictions on our choice of materials and assembly methods, as well as requiring a protocol for decontamination and removal, probably with assistance. It's recognised that removing or doffing PPE is a high risk point for accidental contamination. So, as the previous speakers mentioned, somehow on a very short timescale, within 72 hours, we produced the first prototype Perso. This uses a HEPA filter, much like that found in your vacuum cleaner or dehumidifier, which should in theory capture both the most common fomite or droplet sizes, which are produced during talking, coughing or sneezing, as well as much smaller individual virions or virus particles. And I can discuss the mechanics of that for anybody who's particularly interested later on. It's important to note that not all HEPA filters are equal. There is a standard again, so we tested 2 particular grades. The filter is matched with a centrifugal fan and a flexible pipe up to a headset. This is made from an adjustable head harness taken from a brow guard or a hard hat, and is covered with a hood, which in this case was sewn from Tyvek material obtained from a protective lab coat. We designed semi-universal 3D printed connectors so that components might be interchanged due to availability of different parts in different areas, or for different hoods. For example, different levels of protection might be required for different users. For example, people working on normal wards compared to anaesthetists who might be performing procedures which generate aerosols such as intubation of critical individuals. The assembly was worn in a runner's bag belt to be worn around the waist, weighed in total 1.4 kilograms. We produced a second round prototype within a week using a more customized headband designed with the help of McLaren Racing Limited and various other design changes, including an updated hood from Kent Sales, which is shown on the later slide. And this went on to pilot user feedback and preliminary tests at University Hospital Southampton. Now, we aren't set up as a full testing facility to the standard that I mentioned earlier. Remember, we're only just over 1 week into the project at this stage, but we conducted some representative preliminary tests. Now, qualitative fit tests of respirators currently used in hospitals involve spraying a fluid with a bitter taste and asking whether users can detect it. The spray droplets correspond with the size of the cough and sneeze droplets that might be the infection risk. This is followed by spraying a positive spray test under the visor hood, which the user should be able to detect. We also conducted a similar tests with cigarette smoke, which I hasten to add was approved by our respiratory doctor co-author, to test against much smaller particle sizes. Second, we tested the device's filtration efficacy by placing agar plates inside and outside the hood and exposed them to 1 cubic meter of airflow, and then we incubated them at 37 degrees for 24 hours. The plate which was inside the hood, the one on the left, showed no so-called colony-forming units, whereas the control plate showed 10. You might have to zoom in and see through the dust on your monitor, but there are a few small white specks on that right-hand plate. We had extensive user feedback regarding comfort for skin health and temperature, a greater feeling of safety, easier communication, except for scenarios like hearing particularly weak patients speaking and using a telephone. An off-the-ear hood design might also assist with stethoscope use for nurses, for example, working on wards where patients are not on heart rate monitors. However, one of the most common items of feedback from users and patients was that they did like being able to see the wearer's whole face, and that this improved their care experience. Now, while we have delivered a prototype which passed some preliminary tests, very importantly, this is not a product. Moving from established healthcare PPE to a new system requires very careful evaluation of risk. This prototype was not fully tested or approved for use, and the presented tests are obviously very short term. So the next requirement was to identify the device's duration of safe and effective operation. The government has provided some very helpful updates to the regulatory approvals processes to acknowledge the urgency of our current situation, whilst making sure that new PPE devices do not inadvertently put people at risk. Likewise, we needed to design carefully cleaning and removal protocols to make sure that users aren't inadvertently contaminating themselves at the end of a shift. We also tried to avoid directly replicating any existing devices, as there may be intellectual property risks around reverse engineering commercially available PPE or ventilators. Governments might be able to invoke legislation like Crown Use Exemption to authorise use of IP without the owner's agreement, or the World Trade Organization's agreement on trade-related aspects of IPR. However, well-meaning individuals should be aware of the legal risks in this area, not necessarily rely on the likely negative publicity, which might short-term deter intellectual property owners from taking action over infringement. So as a university, we recognised the need to bring in some industrial partners to support us, especially on the verification testing, quality assurance and scaled-up production. And I'm delighted to say that with their great support, news was shared yesterday that the first devices have been delivered to the University Hospital Southampton and are being worn on wards of an initial order of 5,000. And new users are being trained in their device and fitted with devices now every day. We're continuing to work hard to maximise the benefit and reach of this technology. So we've also published an open specification paper for the device on Engineering Archive, which is given on the event webpage for this webinar. And we're aiming to make the full design open source very soon. We're just preparing the CAD data right now. So what's next? In the same way, we're now working hard with partners to achieve nationwide availability. And we've begun the follow-on Perso DW project for users in the developing world and other low resource settings, for which we've recruited a larger team. We're also keen to hear from international non-governmental organisations who might support with this. Thank you very much indeed for listening. And before finishing, I'd like to acknowledge our industrial partners, McLaren Racing, for their support on prototyping, both Indo Lighting and Kemp Sales, without whom this would have remained just as a prototype. I also have lots of co-authors to thank and various other supporters and advisors. This project came from a very dedicated team across the University of Southampton, working around the clock and 3 weekends, and I'm just one contributor. I'll be very pleased to share more information with anyone who gets in contact and to answer your questions at the end of the webinar. Thank you.
Thank you, Alex. A really interesting case study and such a rapid response. It's quite amazing. So we're now going to move into the panel session. And in addition to Helen, Bassett and Alex, we are also joined by Professor Sam Turner, who is the Chief Technology Officer at the High Value Manufacturing Catapult, and Michael Strawn, who is the Chief Operating Officer for Sunseeker International Limited. As we have heard from our first 3 speakers, I would like to invite Sam and Michael to give a quick 2-minute introduction about their work in responding to the challenges of COVID-19. So Sam, if you would like to go first.
Thanks, Jen. Yeah, so I'm the CTO of the High Value Manufacturing Catapult. We're a network of manufacturing innovation centres in the UK, about 3,000 engineers across the country. And like many other engineering organisations, we've had the privilege of being involved with this phenomenal response to the COVID challenge. Across our centres, working on PPE, mask manufacture, but in particular, the VentilatorChallengeUK. So our CEO, Dick Elsey, has been leading a consortium of businesses from across sectors, particularly aerospace and automotive, to scale up rapidly 2 ventilators from 2 UK companies, one Penlon, an SME based in Oxfordshire, which is an anesthesia ventilator, and then the second one is from Smith Medical, Parapack 300. So these are 2 ventilators that in total are produced at a volume of about 50 a week across the 2 of them. And we've managed to scale this to 1,500 by bringing in some of the kind of industrial muscle, I guess, across aerospace and automotive firms. A phenomenal turnaround. What we've achieved in about 4 or 5 weeks would normally take about 2.5 years. So really quick decision making, engineering, requalification of components, supply chain sourcing, and the real volume production is now starting to hit peak of 1,500 a week across 7 new production facilities on top of the 2 existing ones. So amazing response, still motoring at high pace, and a great example of how engineers can respond actually when some of the barriers are removed really quickly to deliver something phenomenal at scale.
Thank you, Sam. That's great. And Michael, if you'd like to give a quick introduction as well, please.
Okay, thanks, Jennifer, and thanks for the invitation this afternoon. I'm delighted to be on the panel. So my name is Michael Strawn. I'm Chief Operating Officer at Sunseeker International, and some people may know that we manufacture luxury yachts up to a retail value of about £30 million. And I guess I'm here to represent the manufacturing industry and some of the issues that COVID-19 has brought to these unprecedented times. So everybody has seen globally the shutdown of manufacturing plants around the world in a way we've never ever seen before. And when people compare this event with 2008-2009 recession, of course we're in something which is completely different, a health crisis and economic crisis at the same time, which has meant that many of us who've been in industry or manufacturing for a long time have never ever been prepared for what we're having to face at the moment. You know, we've learned a new word, furlough. We've got many staff who've been furloughed all across the nation, and all of the issues that staff either working remotely or being remote from their facilities, all the issues that brings. And I think one thing that comes through very clearly at a time like this is communication, not just with employees, but also stakeholders, customers, shareholders and suppliers. And there's a sense of nervousness about what comes next, no matter what industry you work in. And of course, as the lockdown relaxes and we've seen Italy, Spain, now Germany move into a different phase, then the British manufacturing industry has got to turn its attention to the restart, and particularly the welfare of our people when we do return to work, and how we will take care of our people in quite uncertain times when we know that actually we're not clear of this virus and it could re-peak at any time. One thing I'd like to say as well is that in the meantime, we've tried to keep our staff very engaged in the crisis and how we can help. And, you know, if anybody made a ventilator out of glass reinforced plastic, wood or leather, we'd be the best manufacturer for that ventilator. But of course, that's not the case. And therefore, we've turned our attention to the supply of face masks and gowns. We've set up a small production line at our facility here in Poole, and we are about to supply the Poole NHS with much needed PPE. Delighted to be here, and I'm open to any questions you may have. Thank you.
Thank you, Michael. So we're now going to move into the question and answer part of the panel discussion. Now, there are quite a large number of people on this webinar, and I will try and get through as many questions as we can in the next 20 minutes. So the first question is for Bassett, and it's really about whether there is a typical background for a volunteer who's coming forward to help out in the NHS.
Yes, sure. In my presentation, I mentioned the healthcare science communities and how they are redeployed for the role. So in terms of background from the healthcare science community, there are the roles varies quite a lot, from lab sciences to more patient-facing in physiological sciences and less patient-facing roles in medical physics or clinical engineering role. So when we selected these volunteers for the critical care science and for the clinical engineering roles, we selected we selected healthcare scientists with more patient-facing experience for critical care science role. And those healthcare scientists with less patient-facing experience, like medical physics or rehabilitation engineering, they were well suited for the role of clinical engineering, because we wanted to make sure they have skills already there and they could be transferred as quickly as possible. So those who have patient-facing experience, like audiologists, cardiac physiologists, vascular science colleagues, in respiratory and lung function colleagues. So they see patient day in, day out. So we utilize them first for the cardiac sciences one. And in terms of if we look at the more generic one, the other volunteers that Helen mentioned, we looked into the broader, a lot of types of experiences. We created a JD, as Helen mentioned, and I think the emphasis was made on the skill set they have, the engineering, electrical, electronics, or mechanical engineering skills they have, and there are a few other criteria as well.
Thank you, Bassett. And there's a question here that I think I'll field to Helen. And we know that the selection for engineers to volunteer in the NHS has now been spread out to Wales and Scotland as well. Is the same process for the selection and training of the auxiliary engineers being followed in those regions as well?
Yes, I mean, obviously Nightingale London was the first facility to be constructed, so they really laid the ground rules, if you like, for the kind of role that was being looked for, and the other Nightingale hospitals have also followed that process as well. So the work that was initially done at London has really, set the bar in terms of the sorts of engineers that are being looked for. And I mean, obviously, it will vary from region to region depending on the sort of skills and equipment and so on that they have. But in general, as Bassett said, we've been looking at areas such as electrical safety, PCB diagnostics, even things like building services and for gas and air and those sorts of things. So there's a whole range of fields which these engineers will be covering, which will support the clinical engineers in doing their job, which will be working more closely with patients.
Thank you, Helen. So I've got a question now for Sam, and it's about the rapid process that we've gone through in the design of new ventilators in the UK. And there is a question about if it becomes the case that the UK doesn't necessarily need all of the units that are being manufactured. Will those be made available to others elsewhere in the world?
Well, that's ultimately a government decision. I think that is the intent, and certainly the hope of all engineers working on these. There's going to be huge demand globally, and other nations and regions are perhaps behind us in terms of the curve that we've seen. So that is an expectation, but that's ultimately a government decision. Where we have stock of full ventilators, it's obviously the right thing to do to share those around the world. And we've got a range of specifications as well that will meet different needs and different purposes. Some of them are full ICU spec, some emergency response. So I would expect that will happen absolutely if we have surplus need for the UK.
And just to add a little bit to that, Sam, do you think that this process that we've gone through in terms of how we collaborate with others has enabled the UK to become more advanced in the processes around developing prototypes, not just for ventilators, but for other things as well?
Absolutely. There's lots of lessons we can learn here. I mean, we're still in the thick of this, so the kind of reflecting and looking at how we can scale this learning into other sectors of the products is recognised we need to do that. Some of the thinking started, but we're still very much in the thick of ramping up and delivering the ventilator requirements. But yeah, huge lessons to be learned here. The timing, even putting things like contracts in place in a day or two's turnaround with legal teams, but the ability to very quickly design, iterate, quality check, verify, build prototypes, scale those to volume production, source supply chain components internationally. It's a phenomenal learning curve, and there's lots of things we can learn there about focused self-organising teams, appropriate delegation of authority, really clear mission and focus and concise communications. And there's been a lot of hard work, of course. The pace of work is not sustainable under normal conditions, but the process we've gone through could absolutely be applied to a range of different products and learning. And I think there'll be a lot of reflection on what's been achieved here and how can different sectors and companies learn from it.
Thank you. The next question that we have is for Michael, and it's about the production of PPE. And the question was the decisions that you made driven by your local NHS trust, or did it come from the government? And how did you go about reconfiguring your production lines to suit the production of PPE?
Thanks, Jennifer. When we first closed down, which is probably 4 weeks ago now, we already use medical standard PPE, face masks and eye protection in our facility. So the first thing we did when we closed down was we cleared out our stores and we took it all to Poole Hospital. They agreed that the specification was correct. So we had already established contact with Poole Hospital at a very early time during the infection outbreak. I think last weekend when we heard on the news the issues that hospitals faced with PPE provision, we decided that we would first of all make sure we could get volunteers from furloughed workers to work on a special project. We have an upholstery section at Sunseeker where we make covers, bed linen for luxury yachts, and we knew we could turn our hand to making something for the local NHS trust. The difficulty was getting a pattern which was okay for use in a clinical environment. We tested the first samples this week. We've got some modifications to make to it. So hopefully by Monday we'll have an approved face mask, an approved gown that they can use immediately. So fingers crossed we get approval this weekend.
Thank you, Michael. The next question that I've got is one from Frank Mills, and it may be a question partly for Helen and Bassett and possibly for some others on the panel, so I'll go to Bassett first. But COVID-19 is an airborne disease, and if so, why does Public Health England, and I'm assuming Scotland and Wales as well, not mention ventilation in its guidance on reducing the risk of transmission of COVID-19 in a hospital setting? So Bassett, if you'd like to answer that first, if you can.
I'm not sure about this report or information, because if it is, there is a lot of information on the media and social media and channels, but we follow, or NHS is followed the guidelines from reputed evaluations, and I'm not sure about this, whether it is an airborne and how I think if it is the case, then we would have clear guidelines from the government, from the leads in the medical and scientific directorates.
Thanks, Bassett. Helen, do you have a view on the type of engineers who are coming forward? Are some of those looking at buildings management as well?
Yes, we did. We did include building services as one of the criteria for any engineers, and indeed we've had an awful lot of civil engineers come forward to volunteer with their time and help. Obviously, Bassett and myself are focused very much on the clinical engineering, but the estates management side of hospital care is just as vitally important, and often clinical engineers and building services engineers work very closely together to be able to manage equipment and facilities within hospitals under normal circumstances, of course. This, I think, is an unprecedented situation, and so drawing on engineers who have a wide range of skills and experience will help to solve an awful lot of problems across the Nightingale hospitals, which may not have been considered in a standard hospital facility. So I think that there's an awful lot to look at, and whilst I don't believe I have the right qualifications necessarily to answer Frank's question per se, I think I would say that there are engineers who are obviously looking at these particular things, and this will be something that will go on for some time. This is not necessarily a response we're going to address during this particular crisis, but actually it has brought to the fore a number of issues that our engineers are going to have to tackle in the long term. And I think that's something that will need to be addressed in new processes and procedures, new regulations that will be developed following this crisis. And I think that's an important part of what engineers will do.
Thanks, Helen. And I think on this question too, I'd also like to come to Alex, who has a little bit more information on whether or not COVID-19 is airborne. Alex, would you like to come in here?
Yeah, thank you very much. So we did a bit of reading around this in developing a PPE device, because far and away the best place to start when you're developing PPE for avoiding infection is to look at the infection route. And we're learning a lot every day about this disease, so we don't know for sure. But most of the evidence that we found early on is that this particular infection is likely to be primarily droplet-based instead of airborne for most people. So this is, I understand, the justification behind the 2-meter rule that we've been asked to observe for social distancing. That these fomites, so these little droplets that we generate when we talk or cough or sneeze, may not travel more than around about 2 meters. If you're looking at airborne infection rates, that's why I was mentioning the anaesthetists where they're putting people onto ventilators and they're performing procedures like intubation. Those are more likely to generate these aerosol particles, more likely to lead to an airborne infection pathway. But for most of us, that seems, with current evidence, to be less likely.
Thanks, Alex. And I'd like to ask you the next question as well, and it will also hopefully give you an opportunity to highlight some of the opportunities you have for other engineers to build their own respirators. And that's a little bit around what was the kind of initial budget and cost for the respirator that you developed? And was that a fixed budget, or were you kind of free to do whatever you needed to do?
So we didn't define ourselves an immediate budget right at the beginning, because we were motivated by availability first and foremost. If we reached a point at which commercial devices were completely unavailable, then with whatever budget we would need to come up with something. So we have these two streams. So first of all, I suppose the Perso one, where we were simply trying to find off-the-shelf devices, and we were looking for components sort of in the cost of tens of pounds, but also obtaining materials from other sources, where I mentioned taking a Tyvek lab coat, which can be as a source of material for the hood. And similarly, we looked at vacuum cleaners, where you might have access to these flexible tubes. So it was as much about trying to find existing components that we might already have or be able to purchase. The same with hard hats or brow guards for the headgear. This is especially important for the second stream, which is the Perso DWs, the developing world option. And they were looking for any kind of recycled or repurposed materials which you might be able to use. And in particular, if there are necessities around cleaning protocols to make sure that some piece of repurposed or recycled material is safe to use in a respirator device. And so we didn't set ourselves an initial budget. It's the lowest we can. But that's some of the thought process in our component and material selection around that.
Thanks, Alex. The next question that I have is from Joe Flake, and it's for Sam. What were some of the practical considerations for manufacturers as they pivoted production? How useful was augmented reality for quickly and safely sharing manufacturing knowledge?
Well, augmented reality actually has been one of the solutions we've used for training manufacturers. So particularly, I mean, there's two distinct parts to this, of course. One is sourcing all the components, supply chain, through supply chains. Some of those are scaling up existing supply chains, but many of these were turning manufacturers who may be from completely outside the healthcare sector to look at new electronics parts, machined metallic or plastic components, and prototyping of those. But the assembly lines, which is where the larger automotive and aerospace OEMs and tier ones have come in, that's where the knowledge and skills that lies within the existing companies like Penwell and Smiths is really important. And AR has been part of the solution to train the trainers and train the assembly line operatives. And you can imagine actually taking people out of the existing businesses who've been delivering these crucial devices at small scale isn't really an option. So augmented reality, remote experts has been an important part of that solution for some of the more complex assembly processes.
Thanks, Sam. Michael, have you got anything to add on this?
Sorry, Jen, not really my speciality. I think Alex has come up with a fantastic answer there.
Okay, thank you. The next question that I have, and I think it's probably for Helen, is there anyone recording the efforts that engineers are putting into the COVID-19 response? It seems a good opportunity post-COVID to help show the public the value of engineers in this country.
Absolutely, and what a great question. Yes, there are a lot of organisations who are doing that. I certainly am aware that the Royal Academy is recording many of the case studies, if you like, of engineers who have been involved in various aspects, to be able to show wider society the importance of engineering in this particular case. And also, you yourself, Jen, will be aware of the This is Engineering programme that was run by the government, I think, over a year ago now. That programme is still running, and they are looking to put together documentation to share with schools and STEM ambassadors and so on, to be able to demonstrate to young people the value of becoming an engineer. And I think that's going to be vitally important in the future, particularly to help children through this sort of period where they can understand what people's contributions have been to these sort of things, particularly in Michael's case, turning his company over to making other products is a great demonstration to young people of the versatility of this profession and the flexibility with which engineers can adapt to situations. And what a great way of showing people what a wonderful career it could be for them.
Would you mind me to add on?
Yes, please, Bassett. Thank you.
Very well summarized by Helen. Just a few bits more that we highlighted clinical engineers or critical care scientists, and that is really a very small portion of the engineering support if we just look at a hospital level. So, for example, even the engineers who are making sure that a lift is working absolutely fine, so we can transfer the patient from that to those who are making sure the oxygen is available and has the proper supply, to those who work on the Nightingale hospital, making sure the air conditioning is absolutely okay and the infrastructure. So there is a huge role of engineers and engineering community in COVID response, and definitely, I think it's a very good comment, and it needs to be highlighted and emphasized to document in a better way.
Thank you, Bassett. And I think this next question may also be for you. But there seems to be a sort of general view that ventilators have now been developed, that we've sort of resolved that problem, and they were the main medical device that was coming up as being something that we were short of. So what's the next most important engineering design and development challenge that we may see coming up next?
It is a very dynamic environment, as we appreciate, and information and challenges are coming on daily basis. In post-COVID, for example, there are going to be perhaps new ways of, just taking a very simple example, there are engineering tools for opening a door without touching with the hand, using a foot. So I'm taking a very basic, simple example, but this is a very critical one. So our new normal may be different post-COVID, and engineers are going to play a very critical role in not only hospital environment, but perhaps day-to-day, how we deal and do shopping, for example. So engineers, I think they are going to play a huge role, and we need to keep an eye open and use our innovative skills to find solutions as soon as the problems are emerging. But it's very hard to pinpoint as right now to envisage what next challenges are. But there are many, of course.
Thank you, Bassett. We've really only got time for one final question, and there's actually lots of people asking this question. So Helen, I'm going to ask you to respond to it. And it's really about how people can get involved. So not just how they can get involved as a volunteer, but how their company or as individuals they can put forward designs or offer their services in order to support the needs of the NHS. Could you give a sort of brief summary of the different options that are available to people?
Yeah, sure. There are an awful lot of organisations out there who are collecting, shall we say, people's ideas and thoughts on what could be done. Obviously, most people will be aware of the various government calls that have been put out. They've been made very public across different media platforms, and you can find those obviously at the government websites. But organisations like Innovate UK, for example, have put out a funding call to ask people to come up with ideas for solutions. As Bassett has pointed out, things as simple as opening a door without touching it is a difficult thing to do. And there have been some great ideas, some very simple 3D printed tools to do that. But we need long-term solutions, and that may involve automation. It may involve robotics. There may be all kinds of things that people could put their minds to post-COVID. So I think there are those sort of areas. The Royal Academy of Engineering has also been triaging quite a number of ideas and making sure that those ideas get to the right place and the right people. And so that, yes, there are quite a number of organisations. Also, the institutions themselves have been very good at collating ideas from their members and passing them on to relevant organisations. So I think if I was going to give any advice to people, it would be reach out to, if you're a member of an institution, reach out to your institutions, reach out to the government bodies that are put calls out for help. And also, I think after we are back to some kind of normality, get in touch with hospitals. Reach out to the engineering teams at hospitals, find out what you can do, and even maybe consider becoming a clinical engineer. That would be a great opportunity for an awful lot of people in the future.
Thank you very much, Helen, and thank you everybody for your questions. We had a lot of them, so we tried to get through as many as we could. And those people who have asked very specific questions to individuals, they may be responded to separately. And we may look at whether or not we can put together a Q&A after this with our events team. So I'm now going to bring this webinar to a close. I would like to thank all of our speakers for giving us their experiences and some really interesting stories and fascinating opportunities for the future. And I'd like to thank all of you for watching and listening, and I do hope that you'll join us again soon. All of our upcoming events can be found on our website, and we will very soon have a dedicated webinar page that will give you information about upcoming webinars and also webinars that have already happened. So that's it for today. Please everybody stay well, and thank you again for listening. Goodbye.